Okay, so any questions from last time? Apologize for being late. I blame it on the gentleman ahead of me who was vaping. I don't know what he was vaping in particular to drive as bad as he was, but not that vaping speaks to his character at all, but it doesn't help, right? So, anywho. So, talking about chemo, we talked about some agents that affect things like DNA synthesis. We talked about purine, pyrimidine synthesis. Next up, we have what we call our alkylating agents. And so these are probably the oldest drugs that we have as far as chemotherapy goes. And so these actually got their start back in World War I. So does anyone know the textbook for the course? Anyone remember the name of that? It's in the syllabus, I guarantee you. It's called Goodman and Gilman's Guide to Therapeutics, but Goodman and Gilman's kind of pharmacy Bible for us pharmacy nerds. And so these guys were working back in like the World War I time frame. They actually found that mustard gas was a chemical warfare agent that was used. It was a very strong vesicant, caused very severe blistering, damage to mucosal tissue, all kinds of things. The secondary effect of that, actually found it was carcinogenic. It would actually cause cancer in some of these soldiers who are being affected by this. But they said, wow, this stuff is really interesting how it can destroy this tissue. Maybe we can try to use it for a therapeutic effect. And so they were able to adapt it. And so when we talk about, our kind of mustard-based kind of alkylating agent, this is kind of what it's referring back to. It's very old drugs. And again, mustard gas is no fun thing to kind of be hit with. So fortunately, we've gotten away somewhat from using these kind of chemical warfare. But it's interesting to see kind of the agents, the genesis of some of these drugs we have here. Anyway, the way this is going to work is basically it's going to alkylate to DNA essentially. So it's going to form these covalent bonds. Some of these you're going to find can have kind of interstrand bonds. So you can kind of bind two strands of DNA together. Obviously, that changes the conformation, makes it difficult for things like RNA or DNA polymerase to work on it. It can also cause bindings between single strands, right? So you can kind of bind up two different sections. And I'll show you some pictures of that in just a second, kind of make that a little bit more clear cut. These tend to be cycle non-specific, so these can work potentially anywhere within the cell cycle. We mentioned a lot of things like, say like your vincristines, like your vinca alkaloids. When would those have worked? Do you remember that mechanism? They worked on assembling the microtubules, right? And so microtubules are really important for which phase of cell division? The actual mitosis, right? So those would be in phase specific, whereas we're going to find that these tend to be cycle in non-specific, right? So they can kind of work. I like that little hand motion. That's good. Because it's pulling apart of the chromosomes. But anyway, so these are going to be able to work whenever. You'll find that typically, if you did something like methotrexate, also is working more, towards like, the S phase when you're actually generating DNA. You would give that over, a long period of time, say like a big dose over, say 4 days or something like that. These agents, you can typically just give it like kind of one big solid dose, and like it's going to work on all of those cells regardless. That also means we lose even more selectivity for those just focusing on rapidly dividing cells. They tend to focus on a lot of other types of cells as well that may not be actively dividing, which means you're going to cause a lot of damage here, right? So it's going to cause a lot of toxicities associated with them, but they're very, very effective at killing off these cancerous cells, so we still get some utility out of them. So these are definitely going to be cytotoxic. They're mutagenic. Mutagenic just meaning what? They don't give you superpowers. I tried, doesn't work. But you could actually see mutations in the DNA, which can cause secondary leukemias and other types of malignancies. They're definitely tritogenic, so definitely causing birth defects and whatnot. So watch out for this. In general, as a class, they also cause pulmonary fibrosis. So this is one of those things you want to monitor things like PFTs over a period of time to make sure that they're not developing this. There's going to be a few agents that are a little bit worse for that than others. When you look back at Chemo Man, you'll see that he has big Bs for lungs, and that is referring back to busulfan. There's another couple of bleomycin. Those are the two main ones that we'll be kind of focusing on from that standpoint. Anyway, and mustard gas also smells like garlic, so that's one of the things they tell soldiers to look out for. They're like, hey, if you get this kind of horseradish kind of garlic smell, like get away, right? And or put your gas mask on to try to avoid exposure to that. Anyway, so the first ones we have are nitrogen mustards, which again, not something you want to put on your hot dogs, but if you did have cancer, it could be good drugs for you. And basically, the two main ones we're going to use here in this category include cyclophosphamide, sometimes referred to as CPM, and then ifosfamide. So these are going to be agents that, again, they're alkylating. You can see here when you start off with a general kind of nitrogen mustard structure, you'll lose these chlorides. They become much more reactive, and you'll see that they can interact with things like guanine. So they'll actually bind to guanine here, and eventually what you can see, if you're looking at the DNA strand, you can see how they'll form these kind of interlinked connections here. And again, that's going to damage the DNA to a point where generally it's going to stop replication. You're going to see eventual apoptosis of those cells and eventual cell death. So it kind of makes sense how those are working there by causing these covalent bindings. We use them to treat tons of different types of solid tumors, hematologic cancers. We'll find some drugs that are very, very specific for just one type of cancer. These tend to work for lots of different things because of that effect that they're not really cell cycle specific and they can just work on many different cell types. One of the other things to note here is a unique sort of side effect you see with cyclophosphamide and ifosfamide is it forms a toxic metabolite called acrolein. And acrolein itself actually binds to the bladder and can form and cause what we call a hemorrhagic cystitis. And so it's really important that we have a specific antidotal agent we use to prevent that. So it's another one of those kind of key antidotes you want to think about. So that drug we're going to give there is called Mesna. The full name is mercaptoethane sulfonate, but just we all call it Mesna. And basically what it can do is bind to that acrolein. It will bind to it, inactivate it, and prevent that from causing a hemorrhagic cystitis. The other big thing, and you'll find this with a lot of chemo regimens, is that hydration is super important. So we will vigorously hydrate the patients. They're getting well above what we consider normal maintenance fluids for a patient, sometimes 2 or 3 times that, in order just to keep the the kidneys replete with fluids and kind of flush things out as quickly as you can. So that's another big thing to focus on. You guys remember, for methotrexate, what type of fluids we were giving? It's an important thing. It contained a specific agent. Think of sodium bicarb, right? So again, with methotrexate, you're thinking hydration with sodium bicarbonate. You don't need to do that with this one necessarily. Normal saline is totally fine. You're just giving them a lot of it. Yes, ma'am. So what we would typically do is you'll hydrate with, say, so you have a patient who's getting ready to get chemotherapy. See, they're starting at say 11 o'clock in the morning on chemotherapy. We would start them several hours beforehand with normal saline with say 28K in there or something like that, and we would run that say 125 mLs per meter squared. And so say if you have a person who's 1.5 meters square as far as the body surface area, that's a decent amount of fluid. So it could be getting 200 some odd mLs an hour. They're going to get that flushed through, and that will be for several hours. And then they'll go ahead and get the chemotherapy. And typically we'll actually mix Mesna in with the cyclophosphamide or the ifosfamide, mix that together, and then have that help to bind up the acrolein, because it doesn't inactivate the drug itself. It's the metabolite of the chemo, the drugs that we're actually concerned about, right? So and then we'll do post hydration as well. So after the drug is given, we'll continue to hydrate them, and typically we're looking for things like specific gravity of the urine. We're looking at urine output. We're looking at all those kind of different things to make sure that they're still functioning appropriately. Okay. The other big thing to note with these nitrogen mustards, cyclophosphamide, IFOS is a little bit more predominantly going to cause this as well, is a CNS toxicity. You can see this encephalopathy that can develop. You can also see some renal toxicity kind of goes along with that hemorrhagic cystitis. And obviously you're going to get a lot of nausea, vomiting, a lot of alopecia, and myelosuppression. Obviously, kind of being the running theme with most of these chemo drugs we talked about so far. Next up, we have what we call these nitrosoureas. Again, you can kind of lump the majority of the alkylating agents all together, but it's important to kind of note those little things like, cyclophosphamide, think acrolein, think hemorrhagic cystitis. You can kind of break them down based on their side effects based on that, but again, in general, they all share the same mechanism. They're all alkylating agents. They're all going to be causing those covalent bonds to the DNA. But again, we're going to break these up into general kind of categories based on usually toxicities are the big thing. But next up, we have the nitrosoureas, including carmustine and lomustine. They get abbreviated to BCNU and CCNU. These oftentimes get treated or used to treat a lot of brain cancers because they are very lipophilic, so they have an easier time crossing that blood-brain barrier. And this is kind of a really unique sort of dosage form. So this is a carmustine wafer, and again, this is not the type of wafer you'd probably want to eat. But what they can actually do is they'll open up the patient, there's brain tissue there, and they can actually place these wafers directly after, as say, they removed a tumor. They can place those wafers in there to have a nice controlled release of drug, and that way you kind of get rid of any of those extra cells that are kind of sitting around, right? Because again, no surgery is going to be able to get every single cell. There's no way to know that. So we can give these drugs there. It'll basically just release in kind of a local sense and be able to still treat any of those residual cancer cells that are sticking around. So kind of a unique thing there. I thought it was kind of neat when I learned about that. You can also use some of these to actually help prep patients for bone marrow transplant. What do you think that means when I say we can help to prep patients for bone marrow transplant? Absolutely, yeah. So you got to wipe out all that bone marrow first to get rid of any potential cancer cells patients have, and then we give them new bone marrow essentially to help kind of settle in and hopefully have generate non-cancer cells essentially. So this is one of those things. And so as you might imagine, myelosuppression is going to be a big deal with that, right? It's going to be able to pretty effectively wipe out the immune system for that patient for that temporary time frame. This is also interesting as well, is because you can find that different drugs may cause these naders at different points. The myelosuppression, I should say, at different points. So some of them may be a few days after you receive the drug, some of them may be several weeks. And so this can be kind of a very prolonged kind of delay until you get to really that low point for your white cells. And again, this can be potentially fatal myelosuppression because they don't die because they don't have white cells, they die because they get an infection they can't fight off, essentially, right? And it can last up to 2 weeks. That can be pretty significant. It makes sense why we would use that to help get somebody ready for bone marrow transplant. Okay, next up, so if your patient has really good insurance, that we can give them these platinum analogs. This is only for really the top tier patient. I'm just kidding, we use this for everybody, but they're platinum based, so they're a little bit of your like kind of bougie chemotherapy a little bit there. 3 drugs this is going to include is cisplatin, carboplatin, and then oxaliplatin. So they have the plat in there. You can know it's kind of a platinum-based chemo drug here. And so again, these are going to cause the same sort of mechanism as you see with the other alkylating agents. Again, they're going to cause either interstrand crosslinks or they can form an intrastrand crosslinking here. And again, these are all binding to guanine typically to form these covalent bonds here. As far as toxicity goes, the unique things here you're going to see is this one is pretty big for causing nephrotoxicity. This is another big one we need to give pretty vigorous fluid hydration to, right? And then the other thing is you can actually see ototoxicity with this one. So they can have direct damage on the hair cells and the cochlea. And so because of that, we need to monitor for things like hearing tests, at either a baseline and then do a follow-up to make sure if the patient is complaining of tinnitus or any kind of muffled hearing, things like that. Those should be kind of warning signs that may preclude you from using any more of these platinum-based drugs, essentially, right? You don't really get the same kind of dose-limiting effect like we saw with things like daunorubicin. You guys remember why there's a dose-limiting effect on those anthracyclines? The dose-limiting toxicity. It was a cardiomyopathy, right? Because it causes free radicals to generate, and they cause pretty significant damage to the heart. So you'd have like a lifetime max that you could hit on those. You don't have the same thing here, but this is again just something you monitor for, looking for hearing acuity over time. Again, this is another one. These are pretty notorious for causing very severe nausea and vomiting. These regimens containing platinum-based drugs, they usually end up having to be on 5 or 6 different medications just to deal with the nausea and vomiting. So you can see where the adjuvant therapy, which we'll talk about a little bit later, can be so important to make sure the patient is having any sort of quality of life and is not getting really dehydrated or having malnutrition due to this nausea and vomiting. All right, some other alkylating agents. We have things like dacarbazine and temozolomide. These are going to also have the same exact mechanism here, but again, we're just kind of referencing them just so you have an idea when you see these drugs, kind of what type of chemo they're actually going to be. So again, nothing specific as far as toxicity goes, but just in general, alopecia, myelosuppression, nausea, and vomiting. Temozolomide is kind of nice because it actually is has an oral variety that's available. A lot of the other ones we've seen have been IV only, and so this one has the oral option, which is nice. Patient need to take that on an outpatient sort of basis. Here we have busulfan or Mylaran. This one is going to be acting very similar to other nitrogen mustards. The reason why I separate this one out is because, again, this one's really bad for causing pulmonary fibrosis. You can also see some risk for things like hepatotoxicity, which we know is a problem with things like methotrexate, but we see it come up here again. And here we're going to see seizures can also be at risk. So especially if they're not able to clear it very well, they have hepatic dysfunction or something like that, they hold on to it, they can see seizures develop, or there are signs of altered mental status. So again, watch out for that one and the pulmonary fibrosis. Okay, so those are the alkylating agents as a group. Remember, they all have the same mechanism, but be able to kind of pick out those different side effects. And if you see something like cyclophosphamide, know that mesna is going to be the antidote for that. Or if you see something like cisplatin, know that can cause something like ototoxicity. So kind of be aware of those kind of differences there, because those are good testable factoids on the test there. So just wrote yesterday, and essentially the breakdown of the test, just a little FYI, since we did 2 sections of cardio, we did 1 section of heme, and then we did basically these 2 sections for chemo. It's kind of broken down via a little bit heavier on the cardio stuff. The second would be chemo, the oncology stuff, and then heme is kind of the third place as far as the number of questions go. So use that with what you will, but again, you should know everything from here because this is all valuable information, right? I'll take your silence as a resounding yes. So next up, we have some hormonal therapy. So we can actually affect the endocrine system to help us to fight some of these cancers. And so you might imagine, things like estrogen. If you just had estrogen around, that can be carcinogenic in and of itself. Things like testosterone can be carcinogenic. What type of cancers might you see with an excess of testosterone? Yeah, prostate cancer can be a big one, right? If we had too much estrogen activity, we could see breast cancer. We could see ovarian cancer, cervical cancer, endometrial cancer, right? So anything that any of these tissues that are expressing these receptors may be more sensitive to them, and you can see some patients, due to genetic differences. Obviously, we know that family history is huge for things like breast cancer. That we know that estrogen and other types of hormones are very, very important here. So we can kind of monkey with this. We can give drugs that can modify the activities of those hormones. We can do things that can affect those receptors to try to help treat these cancers for our patients. So first off, the androgens and estrogens, these are only going to be effective for hormone-sensitive cancer. So again, if these patients are not expressing those receptors, if they are not able to have these receptors available to really work with these, because again, some of these cancers like breast cancer may be more or less really sensitive to the effects of estrogen. So if they're not really that sensitive to it, these may not be working as well. But some people do have that predisposition to that. But certainly, we kind of mentioned all these already. And so we're going to find when we look at these therapies, they're typically used to either antagonize the receptors themselves, so they will block the activity of those hormones at those receptors, or they will prevent the actual production of sex hormones, as we'll see in just a little bit. So what do you think could be some of the side effects of if you antagonize receptors? Like, what if you antagonize estrogen receptors? Symptoms of menopause, right? So you can see things like hot flashes, right? Or power surges, as my mom likes to put a positive spin on things. What else could you see? Yeah, so potentially if you have more kind of, if you're blocking like estrogen activity, you have more androgen activity, potentially you can see things like hirsutism. You can certainly have a lot of irregular bleeding. You can have vaginal dryness, like things like that can occur. If I was blocking testosterone activity, what could I see? Gynecomastia could be one thing. If you have, obviously it's a balance between the two, right? And so if I kind of tip the scale versus one or the other, this is where you see those side effects. So we're kind of familiar with those for the most part. That'll be important when we're looking at these in just a little bit. The other thing we can use is corticosteroids. And I kind of mentioned these already, but again, what do corticosteroids typically do to your immune system? They suppress it, right? So again, this is nice because you can help a lot of leukemias by helping to suppress that. And you'll see that patients will come in, say, to the infusion center. They'll get a big dose of their non-specific, say, cyclophosphamide, and then they'll go home and they'll be on this prednisone or dexamethasone or something kind of more consistently in order to help kind of have a more kind of consistent suppression of the immune system there. So that can be very useful from that standpoint. You'll also find that it can also be used to help treat chemo-induced nausea and vomiting, and so it kind of works more on kind of a central mechanism. We'll cover that more in the GI section next semester, but essentially it can be useful there as well. So you ever see someone getting that as part of an antiemetic regimen, that is why, usually chemotherapy. And typically you'll see things like prednisone, dexamethasone, hydrocortisone is another very common one we'll use in these patients. And the other thing to think about is some of these drugs can cause hypersensitivity, so they may also have corticosteroids available as needed basis in case they have an allergic reaction to that. So again, lots of uses for corticosteroids that we can use in the kind of the chemo realm. So I mentioned as far as hormonal therapy goes, really a lot of these hormones are working by binding those steroid receptors kind of on or in the nucleus, affecting gene transcription, affecting protein production and whatnot. And so we can see that, as we mentioned, that there's hormone responsive elements, especially if they're expressing more of those receptors that tend to be more responsive, you're going to have them drive that tumor growth. And so you can see very specifically like estrogen-based breast cancers tend to be kind of the most common thing you think about is, people who are more sensitive to that, they have those receptors that can really drive, further growth and production of those cells. So what we can do by giving hormonal therapy, this can help to slow down or help to regulate that tumor growth by antagonizing those receptors typically. Mentioned glucocorticoids obviously affecting mainly leukemias and things like that by affecting the white cells. Obviously anti-estrogens are going to be more in like breast cancer, cervical cancer, and anti-androgens are typically going to be in the testicular and prostate realm, right? So kind of makes sense based on the type of patient you're treating. All right, so just to go over a few of these, and some of these we'll cover again when we hit the kind of the women's health section next semester, but these are interesting ones where basically what we can have here is we call selective estrogen receptor modulators. So if you ever hear SERM, that's what we're referring to. And so selective estrogen receptor modulators. So are all estrogen receptors built the same? No, there's some heterogeneity to them. So, for instance, what type of receptors you find in the breast tissue may be different than you're going to find in the ovaries, right? They're going to be different than you're going to find on the cervix. So, because of that, and also where else is estrogen really important, especially for like older women? Yeah, so bones are the big thing, right? So, if I antagonize estrogen in the bones, that can lead to osteoporosis, which can lead to fractures, which can lead to death. Not good, right? Right, because we see a really increased mortality with these patients when they have things like hip fractures, different things like that, because their mobility, their quality of life just goes down the drain pretty quick. But anyway, so that's really important. So I want to treat the patient's breast cancer, right? I want to deal with that, but I also don't want to cause all these other secondary effects. And so these drugs are nice because they can help with that. Basically, they can act as agonists in certain tissues while acting as antagonists in other tissues, right? Because of the way that the drug has been developed, it is able to kind of select out which type of receptors it wants to activate versus which ones it wants to antagonize. And it all goes down to what type of receptors are being expressed in those different tissues there. So tamoxifen was probably one of the first ones we had there, and we basically found that not only can it be useful in helping as an adjunct to other chemotherapy drugs to help to treat breast cancer, but we could also use it as a preventative measure, right? So especially those women who have a big history of this, especially a familial history, and we know they have these kind of estrogen receptor responsive breast cancers, we can actually give this to them as a preventative method, right? As a ways to prevent the cancer from developing in the first place, which can be very useful. So as you might imagine, we mentioned that the toxicity a lot of times goes with the anti-estrogen effects here. So a lot of hot flashes, certainly going to see some nausea and vomiting. You get some mild suppression, but not really as severe as you would expect to see with like something like a cyclophosphamide or something like Aracy or something like that. The other things you have to consider is because it still has some estrogen activity at different types of receptors you're going to find. And again, here you can see the positive estrogenic effects on the bone and also with on the liver and producing cholesterol, because typically you can see that if you antagonize this, you can have the cholesterol kind of go out of whack a little bit there. But because it has some positive estrogen effects, obviously deep vein thrombosis is the thing you worry about. We'll learn more about that when we get to women's health section next semester. But typically, estrogen agonist activity typically is going to be more of a procoagulant than anything else. That's why you're like, young females who have like no prior medical history, but they're on oral contraceptives, they get a DVT or a PE. That's usually why. It's because that proestrogen effect on the coagulation cascade. But the other thing, though, is that because tamoxifen doesn't act as an antagonist in the endometrial tissue, acts as an antagonist in the breast tissue, but not the endometrium, you're having that kind of agonist effect there. And as you agonize that material, that tissue, it continues to develop, it continues to differentiate, and then you can develop potentially cancer there. So that's kind of one of the problems we saw with that. So this might make a difference if your patients had a hysterectomy or not, right? So do they have this tissue available? Is this something that's been taken out of the equation, essentially? And so that becomes important. So this is why, history is really important. This is why you have to make these kind of different decisions. And we have better drugs nowadays, but tamoxifen was kind of one of the first ones that we used for that. Next, we had raloxifene. This one is, again, another SERM, but here you're going to find that it has positive estrogen effects in the bone and the cardiovascular system, so it can potentially help with cardiovascular health. But here you're going to find it's an antagonist in the breast and the uterine tissue. So for this one, you wouldn't see that risk for endometrial cancer necessarily because it's acting as an antagonist there, also in the breast as well. You can use this one potentially in especially high-risk patients with a history of breast cancer, but also those having osteoporosis due to those positive effects that it has on the bone there, right? So they couldn't receive just a typical estrogen type product. They could receive this instead for prevention of osteoporosis or for treatment thereof. Next, we have fulvestrant. This is kind of a little different flavor of SERM, but here we have a selective estrogen receptor downregulator. So basically, this would help to kind of get rid of some of those extra receptors that make the person so susceptible to the effects of estrogen. Usually comes as like a monthly IM injection. A lot of these products, obviously, you're trying to aim for intermittent use of the patient have to come back in and get injections all the time. But here, this one is going to be a pure anti-estrogen, which means you're going to see risk for things like osteoporosis over time. You're going to see issues with that, but can be very useful for things like hormone sensitive, especially metastatic breast cancer, especially things that are much more severe and kind of more kind of late stage from that standpoint. You kind of notice here how it has that typical hormonal sort of structure, but again, we just change it just enough to where it can actually act as a pure or preventing estrogen from actually interacting with those receptors. Okay. Next off, we have anastrozole and letrozole. These are actually going to be competitive aromatase inhibitors. So what does aromatase do? Going back to physio, remember our talk about luteal phases and FSH and LH surges and all that. Okay, that's okay. Aromatase is one of the enzymes that we need in order to, because remember that a lot of steroids that we have come from cholesterol. Cholesterol is kind of the common precursor to a lot of these, but there's several different interchangeable reactions that occur. Different enzymes are going to be occurring here to form not only progesterone, progestins in general, but also eventually you're going to need your estrogens. Aromatase is really necessary for that. So it's used to help to produce estrogen. If you block that, if you have an inhibitor of that, you're not going to be able to produce as much estrogen. This is going to be useful for those types of estrogen-sensitive cancers. And so this would be one of those things where you could use it as an oral medication for patients who are, say, postmenopausal, who have this estrogen-sensitive breast cancer. It can be very useful there. And as you might imagine, it's going to be causing a lot of side effects related to that. So you can see a lot of hot flashes, nausea, some hair thinning associated with that. And typically you're starting to see this is starting to replace tamoxifen as fewer side effects in general. Tamoxifen, I mentioned, was kind of one of the first ones of these that we had, but you're starting to see a little bit better safety profile for this one, so it's starting to replace tamoxifen there. Next we have exemestane. This is another aromatase inhibitor. This one is very, very much more severe on the estrogen production side, because with anastrozole and letrozole we saw on the last slide, those are going to be reversible inhibitors of aromatase. So that enzyme is not going to be completely knocked out of commission when those drugs are around. However, this exemestane is actually going to be an irreversible aromatase inhibitor. You can see estrogen levels drop about 90%. It's a very, very significant drop. These are typically going to be for patients who are kind of refractory to other therapies, who kind of failed other things and still having progression of their disease. This can be very useful to that. So we mentioned as well, patients, cancer cells, they want to stay alive just as much as any other type of cell or bacteria, so they get resistant, right? They can do things like try to cause mutations in their estrogen receptors, and maybe will make things like tamoxifen less effective. And so instead of just dealing with the receptors, we can say, well, let's just get rid of all the estrogen in the first place, and something like exemestane can be very useful for that. And so again, very kind of later stage there. We're just trying to show you the different kind of places along the chain that we can kind of work here with our drugs to make sure that we can still treat these patients even as they get more progressive, get more malignancies and things like that. Again, as you might imagine, very severe effects of kind of estrogen deficiency, a lot of nausea, a lot of hot flashes, they can have edema, fatigue, all of that is going to go along with that. So it can be a big issue there. But you're going to see that more commonly, you're going to see a lot of these visual disturbances that can happen, and then the bone fractures is the other big thing, right? Because of the anti-estrogen effects we're going to have on the bone, essentially, or just getting rid of the estrogen in the first place. Okay. Next, we're going to have a couple of anti-androgens. I want to not just focus on the ladies, got to involve the guys too a little bit here. So we're going to drugs like flutamide, nilutamide, and bicalutamide. So kind of just a similar naming convention here, but these are going to be synthetic anti-androgens. You might imagine you're going to use these primarily for things like prostate cancer. And so this will bind to the androgen receptor and actually prevent testosterone. And also, what is more potent than testosterone? DHT, which stands for? Dihydrotestosterone. So it's going to prevent testosterone stimulation of the cancer cells. And so we'll look at a few other drugs. We're going to look at leuprolide and goserelin in just a few seconds here to see what those do. But again, as you might imagine, more estrogen effects are going to be the primary side effects with this one, right? So you're going to see things like gynecomastia, some GI distress, because you're blocking. Again, it's not just specific for just prostate tissue. It's going to work kind of everywhere to prevent testosterone from working. So leuprolide and goserelin, these are going to be these are kind of interesting because these are acting as analogs of gonadotropin releasing hormone, right? So basically what these are going to do is actually occupy these LH-RH receptors in the pituitary, and they kind of sit there pretty much continuously. And so what you see is that initially, if they act as analogs, what do you think that would do to release of things like LH and FSH? Well, initially, because they act as because you think back to your negative feedback loops, right? So if initially if I activate those receptors, because it's acting as a GnRH sort of analog, right? What do you think it's going to do? It should increase it in the short term, right? So I should see increases in release of things like LH and FSH. Chronically, though, what you're going to find is that due to the fact that we have all this activity there, we have this kind of constant activation, the GnRH is going to be like, well, I don't need to release anymore. I have all this activity. So that negative feedback loop gets activated. And so you can see pretty severe drops in not only estrogen production, and you would see in female patients, but also testosterone release as well. So again, this could be something that could be used for females or male patients, but we see this used somewhat more in things like prostate cancer or testicular cancer, because it basically kind of shuts down the whole system from the pituitary down essentially. So again, as you might imagine, a lot of side effects associated with that. For male patients, you see impotence, hot flashes, gynecomastia. All of that's going to be related to the fact that you're just losing all that LH and FSH activity. Again, over the chronic period of time, initially you might get a little spike, but then it's going to go back down pretty significantly. So those are just kind of a smattering of different hormonal agents we can use, and see how we can utilize those as adjuvants, as kind of adjunctive agents, along with our other types of chemotherapy drugs. And again, it's not just using one or the other. Usually you're using combinations of things depending on the type of cancer you're dealing with. You're using antimetabolites plus alkylating agents, plus if you're dealing with breast cancer, you're dealing with hormonal therapies. Obviously, being in the peds side, we don't deal with a lot of prostate cancers, we don't deal with a lot of breast cancers, but if you talk to someone, I think Professor Sousa's coming back to do oncology, you guys, she might have more experience with that on the adult side. But I see a lot of leukemias and things, and some brain cancer. So again, my realm is kind of colored by that perspective a little bit there. But anyway, next up we're going to have some biological response modifiers. So basically what you're going to see is that the big issue here is we're going to have these cell signaling pathways that are becoming deranged for these cells, right? So normally these cells should get the signal, hey, I don't need to grow or have mitosis anymore. There's enough cells around, I don't need to worry about that. These cell processes have kind of gone awry for these cells, and that's why they're kind of continuing to grow kind of ad infinitum essentially. So these protein kinases are going to be really important for that. If you guys remember back to pharmacodynamics, remember there's different types of cell signaling. We mentioned there's like nuclear cell receptors. You guys remember those tyrosine kinase receptors? Remember there was things that they were kind of two molecules. They both get activated, come together, and they get phosphorylated, and that can lead to downstream signals afterwards. If you don't believe me, go look at your slides, but I guarantee it was there. Anyway, we have lots of different protein kinases, around 550 that our genome can code for. There's lots of different types of protein phosphatases as well. So again, these kind of work in conjunction with one another, and they're really critical for the cell signaling pathway. So these are important for things like insulin receptors, right? So we need those to have insulin work effectively to have its kind of anabolic effects and affect blood glucose. Things like epidermal growth factor, platelet-derived growth factor. These are so many different critical cell signaling pathways that are encoded by these. But again, it's going to be dependent on the type of tissue you're dealing with, right? So different these kinase receptors are going to be available in different types of tissues. And so what you can see is instead of giving something like cyclophosphamide that affects pretty much every type of cell that's out there, what if we could target it and just be much more specific in affecting individual types of cells, or cells that may be expressing an individual type of receptor? That makes it much more targeted, and so you're going to see that typically you're going to find that these are going to have better side effect profiles, but the other thing is going to be very selective in what type of patients you can actually use them in. So for instance, for some of these drugs, you have to be able to express a particular genetic disposition to express this receptor. If you don't have that, the drug's just not going to work, right? So again, very selective set of patients it might work on, but when they do work, they work great, right? And that's going to be one of the benefits there. I can get cyclophosphamide to anyone, it's going to kill off just about any cell it comes across, but these drugs are going to be much more selective there. So again, looking at these, it should look familiar if you remember back to pharmacodynamics, or unless you've repressed all those memories, that's fine. But you'll have the signaling molecule come along, will bind to these sites here. The receptor will dimerize, and then it gets phosphorylated. Once it does that, then it can interact with those kind of cellular response elements that usually with cancer cells is saying, hey, go ahead and keep growing, right? Go ahead and keep dividing, take up all the nutrients, kill off all this, we don't need this human around anymore, just go and kill them off. They're done, right? It's probably not that malicious, but I like to think about cancer as being malicious, so I feel better about giving it poison. Anyway, so if you can block any of this pathway here, so if I can block either the molecule, the ligand that's actually activating the receptor, that's one thing I could do. I could affect the actual receptor itself, or there could be downstream pathways that I could be affecting as well. So several sites here that I can affect with medications. And so again, this is another one of those things that's kind of rapidly developing. Like we haven't had a new alkylating agent for a long time because again, we were discovering those back in the 1940s, right? These are a new kind of class of drugs. New ones are being made all the time as we kind of determine these specific cell sites that we want to work against based on the type of cancer we have, based on the type of genetic disposition our patient is expressing there. So, and again, this can become very complicated. So you imagine ligand coming and binding. This is the same kind of receptor we're looking at. Again, several different pathways these can go and affect things like proliferation of the cell. They can help to stimulate cell cycle progression, gene transcription. So again, these are just basically just ample opportunities for different targets that we can have with our medications to affect these. I'm only going to give you a small subset of the ones, maybe the ones that are more common that are out there, just to kind of get you familiar with them. So when you see some of these drugs, you'll be like, oh, that name looks familiar. I'm going to go look that up, and I know what that is, right? So, first one we have here is called imatinib or Gleevec. So you'll notice that a lot of these tyrosine kinase receptor antagonists are going to include this IB ending. It just tends to be a kind of the naming convention you see with a lot of these. You're going to find that the nice thing here is an oral medication. So again, anytime you give something orally, it's going to be beneficial for the patient, and it will work for CML, so it's chronic myeloid leukemia, but only if you have this BCR-ABL mutation, right? So the patient has to have a specific mutation. If they don't have that, the drug actually doesn't work. If they do have it, then it works great, right? Because it's able to affect those receptors itself, right? So basically, by doing this, you're going to be decreasing activity of myeloid tyrosine kinases, and that is really responsible for a lot of cell proliferation. So I can inactivate that receptor or inhibit it. I'm going to have decreased cell proliferation, and thus the cancer cells can have a chance for other things to come on, kill them off, chance for apoptosis to kind of take over and whatnot. So again, these are usually given in combination with other chemotherapy drugs to have better kind of cell kill rates, essentially. Again, notice here nausea, vomiting, maybe a little bit of edema, much better side effect profile compared to things like your cisplatins and your cytarabines and things like that. So this is the benefit, but again, very selective set of patients this will be useful for. Another one you can see here would be gefitinib or Aresa. This one is working against the epidermal growth factor tyrosine kinase receptor, right? So again, usually you see a lot of these get kind of fun acronyms that really are difficult to discern in a lot of cases unless you work with them all the time, but they have this ERBB1 or this HER1 receptor, then this will work great. This is actually going to be a useful treatment for non-small cell lung cancer, right? And again, pretty mild side effects, a little bit of GI distress, maybe some dry skin, not a big deal compared to a lot of the other drugs we looked at. So again, very selective, very effective, but again, just more narrow subset of patients you can use it for. Then we have erlotinib. This is a HER1. Again, this is another one we could use for that non-small cell lung cancer. Also use it in some cases for more difficult to treat cancers like pancreatic cancer or head and neck cancer. Again, diarrhea, rash, maybe some elevated liver function tests, but not nearly as, say, hepatotoxic as something like methotrexate. Okay. So again, as long as you can kind of recognize that, hey, this IB ending kind of goes along those tyrosine kinase receptor inhibitors, that can be very useful kind of associations. So you can be like, oh yeah, I know those drugs. I know they're very selective. I know they're only going to work for certain types of cancers. I know they're pretty mild on the adverse effects standpoint versus the other drugs.
Do you want us to know the indications for this one?
Do not know the indications. I'm not going to ask you very specifically which type of CML, which mutation does the patient have to have. That's outside of our scope. This is again more of a kind of a survey of chemotherapy classification. So just know how these drugs are working specifically, right? So just know that okay, if I see something like erlotinib or gefitinib or you kind of notice that kind of naming convention, they'll sound very similar. Okay, I know that's a tyrosine kinase inhibitor. Why is that important? Why is that important for patients versus using something like an alkylating agent that just basically wrecks the entire body essentially, right? Okay, we have another one called lapatinib, and again, this is just a small subset. You may be like, this is way too many drugs. There's like dozens of these that are being developed or have been released on the market. So again, and not something that we use a ton, especially on the pediatric side of things, but it's something that we will, you're going to see just more of it, especially if you work in the hemonc realm. But lapatinib, this one is against this HER2 receptor and also HER1 receptors, and this is actually another one we can use in metastatic breast cancer, especially if it's no longer responsive to other types of drugs. We'll talk about one called trastuzumab in just a little bit later. What do you notice about trastuzumab? It's a monoclonal antibody, yeah. So again, this is going to be, we'll talk about biological agents, and this will come up again just a little bit later. And so you can see how we can use it in combination with other drugs. One called like capecitabine. Remember that was very similar to the 5-FU that gets converted over into that. But you can see that it will increase the time it takes for those tumors to grow. Remember that doubling time we talked about? Usually the shorter the doubling time, the more aggressive the tumor is. And so we can drop that down pretty significantly, from about 4.4 hours up to like 8 hours, or I'm sorry, months in this case. So again, very, very useful to slow the progression of these tumors down, especially if it's something that works more terminal and you're not really thinking about getting a cure. You're just trying to help to improve your quality of life, a little bit of quantity of life there. So this is also useful because it helps to enter the CNS, lipophilic enough, and this can help with the CNS metastases that may pop up there. So very nice. Okay, so this is just kind of the small smattering of tyrosine kinase inhibitors we mentioned here. Next off, we're going to be looking at our biological response modifiers, and so these are the antibodies that we have developed here. And so again, the naming actually matters. So you guys know that to look for MAB, you know that means a monoclonal antibody, but actually these letters beforehand actually are important as well. This kind of tells you what type of source we actually got these proteins from when we generated them. Anyone know what murine sources means? What type of animal it comes from? Mouse, yeah. So ovine comes from sheep, yeah. So we have some antibodies that are developed from sheep. So we talk about like if you ever treat a rattlesnake bite, you have crowfab. That's actually from sheep sources. These proteins, some of them are developed either from kind of mouse-based proteins, and so those are murine based. Some of these are going to be more humanized, and some of them are actually chimeric. So it's kind of a cross between the two. So if you imagine like Master Splinter from Teenage Mutant Ninja Turtles, think about that. They just took the protein from skin. They didn't really do that, but kind of think about the mouse-human kind of hybrid there. I guess he was a rat technically, so that doesn't really count. But anyway. So here's a couple that we're going to look at. Again, what you're going to note about these are very specific. There are certain cell targets that they're going to be going for, and once they inactivate them, obviously it's going to work just like anything else in the immune system. Once it hits an antibody, it's going to get taken out essentially. First one we have here is called rituximab. This one is going to be human murine antibody. You kind of notice this X here usually means it's a chimeric protein. So again, that's more for trivia's sake than anything I'd ever test you on. But it's human murine antibody. The important thing with that is the more murine protein you have in there, what do you think that has an effect on? What side effect in particular? So allergic reactions, right? The more foreign protein I'm introducing into the body, the more human it is, the better off, because again, the body's not going to recognize that as foreign. But for instance, when we used to use antibodies from horses, that's very, very anaphylactic, or is very, very antigenic, very likely to cause anaphylaxis. These are generally a lot safer on that standpoint, because again, it's chimeric, right? So it's part human, part mouse. The mouse bits of the protein increase that likelihood, but not nearly as much as if it was completely foreign from a different animal altogether, right? But anyway, so this can be useful because it works to bind the CD20 receptor, essentially that's the antigen it's going to be binding to, on these B lymphocytes. And so this can be very useful for things like non-Hodgkin's lymphoma because a lot of those cells, about 90% of them, end up expressing CD20 antigen. Cells that don't express the CD20 antigen are just not going to be affected by this drug whatsoever, right? We also mentioned that how do you have to give monoclonal antibodies? Via which route? Yeah, it's got to be IV, right? Or it has to be parenteral in some way. It cannot be given orally due to the fact the proteins are just be getting torn up. Those tyrosine kinase receptor antagonists we talked about before, like lapatinib or erlotinib, a lot of those are oral because, again, they're not protein-based. They're just drugs similar to anything else we talked about. But you can see that CD20 is really important for those cells because it helps to regulate cell cycle activation. So it kind of is going to be one of those triggers when it gets activated to start to kick up the cell division cycle all over again. So if I can bind that up with an antibody, if I can prevent it from being activated, thus those cells are not going to be able to divide quite so well. Right? So that can be very nice. Also, this helps with the complement system to help with lysis and apoptosis of those cells. So it'll be very, very useful from that standpoint. If you bind them up and the cells are targeted already, then they can be gotten rid of, essentially. So typically with these monoclonal antibodies, these are things that are going to be given the time between doses is usually pretty long because those proteins stick around for a while. So you can give it as, say 4 weekly infusions. You just get it once a week for that time frame. Some of these you'll be able to get like once a month in some cases. So it just depends on the drug. But again, you're going to see a lot of infusion-related flu-like syndromes you can find here. Right, so you can again, it's just kind of a mild allergic reaction to the drugs. Again, for the most part, most of this is kind of mediated back towards the hypersensitivity standpoint. So again, maybe a little bit of urticaria, bronchospasm, but pretty rare. That flu-like syndrome is probably the more common thing we run into. And you can imagine some mild myelosuppression because again, what type of cells are we targeting? Targeting lymphocytes, right? We're targeting things that are expressing the CD20. So again, you can see a mild myelosuppression, but if they're not expressing that CD20 receptor, they're not going to be affected. So it's not going to wipe out the whole immune system like something like that carmustine or that lomustine would do, like when you're getting ready for bone marrow transplant. We have alemtuzumab, and again, I just like to say these names, so that's why I'm trying to make you guys learn them because they're fun to say. I'm just kidding, I'm not doing that. But this one is binding against CD52, so this will target cells that express CD52, bind to them, and again inactivate them, lead to the immune system to help get rid of those. So they can be expressed on T and B lymphomas, and again will induce that cytotoxicity. So we can use it for things like CLL as well, which is that chronic lymphocytic leukemias, and again. for the most part, mild myelosuppression. There's some risk for opportunistic infections, but not nearly what you see with things like methotrexate or cytarabine or cisplatin or these other kind of very more heavy myelosuppressive agents. This one is a little different. So this one's not actually targeting the immune cells at all. This is going to be trastuzumab or Herceptin. I think Herceptin you think used for her. So these are going to be effective against this human epidermal growth factor. So you can see sometimes you see this used for breast cancers that express this receptor. So that they have the HER2 or this ERB2 receptor being expressed. And again, I'm not going to ask you specifically. Don't get so granular to recognize like the HER2 or ERB. Just know that, okay, it's human epidermal growth factor. Just kind of keep that in mind as far as like the mechanisms go, so you can kind of recognize what it's going to be working against, right? So if I said it's like CD20 active drug, you're going to think, rituximab. You're going to be able to kind of go back and kind of link those targets back with the drug itself. Anyway, so this is going to be binding to that growth factor. It can help to down-regulate the growth factor receptor itself. Can be very useful, and will help to kind of be useful for more kind of difficult to treat, more metastatic sort of breast cancer there. They're expressing this oncogene, this HER2 receptor on the cell surface. So again, just to kind of show you how we'll use it in combination with other drugs, we can use it with things like doxorubicin, which we said doxorubicin worked as an anthracycline, as an agent that will go and intercalate into the DNA. Remember, it caused that kind of damage there, caused free radical formation, things like that. And then Taxol, you guys remember how Taxol worked? The paclitaxel is the generic one. That was one that formed the microtubules, but then prevented them from breaking down. So you can see we're using different mechanisms of action in order to get more synergy in attacking those cells, right? And again, weekly infusions, again, you're going to see a lot of fever and chills associated with that just due to the fact that you're injecting this foreign protein to the patient. A lot of times you can just treat with things like acetaminophen, diphenhydramine, to help to alleviate those reactions. And here's a new one called meperidine. Everyone ever heard of this drug? It's Demerol is the brand name. Anyone ever heard of that? So this is actually an opioid antagonist, or I'm sorry, an opioid agonist. So you can use this for analgesia. But what's interesting, we don't like this drug very much anymore. We'll talk about it a little bit in the ortho section. But one of the things you can see is called Rigers. You know what Rigers is? Pretty bad shaking, like kind of chills and shivering. You can actually use meperidine for whatever reason. It has kind of a unique mechanism to actually help to prevent that. So you can sometimes see this used in patients who are getting surgery. Sometimes when they're coming out and they're post-op, they may be shivering pretty bad. This can be used to help kind of eliminate some of that. So this is rarely used, but certainly acetaminophen, diphenhydramine, this can be very useful. So we'll talk about this drug a little bit later on, why we don't like to use it very much. So this one's interesting because it can cause, it's affecting those epidermal growth factors. You can see here that it can do things like, cardiomyopathy, which is one of those things that you may not think about as being associated with this, but affecting cells that are expressing this epidermal growth factor. You may see this in the heart to some degree, and so it could be a more of a chronic, long-standing issue that may develop over time with your patient. So again, something to watch out for. Think about getting an echo, kind of a baseline, and then following up later on to see kind of how they're developing. All right, next we have cetuximab. Do you guys mind if I just go all the way through so that way I don't think I have too many slides left, right? You got 20 slides left? It's a few slides. I'm just going to go all the way through so that way I can put the recording with this pretty easily. If you guys don't mind, it'll make it a little bit easier for me. Not too much harder for you guys. Anyway, I was late anyway, but whatever. All right. So anyway, so we have cetuximab. This one is again going to be affecting the epidermal growth factor receptors. Again, we can use this in colorectal cancer. So again, a lot of these cancers will express this receptor. And again, we can figure this out by actually, getting some of these cells and actually doing, going through and finding out what type of receptors they're expressing based on the DNA. So there's tests we can do for that in a lot of these cases. Again, you can also see it can be possibly being used in things like breast cancer, prostate cancers. A lot of this stuff we can't really do good studies on necessarily to, good ethical studies where we can give it, to patients with these cancers, but what we can do is a lot of these clinical trials. We're trying it out, seeing how it works, while still giving them gold standard medication. You're still going to give them other chemotherapy, but you can try it, like for a new indication, see how it may affect those patients there. But again, fusion reactions, it's kind of the most common thing you're going to run into with these drugs. Okay. And then you have bevacizumab or Avastin. This one's actually affecting vascular endothelial growth factor, and so this can affect angiogenesis. That sounds like it's going to be pretty powerful because we mentioned that those cancerous cells, they can help to generate new nutrient supply by influencing angiogenesis, right? So by getting new blood flow to the cells, they can get more nutrients and continue to grow. And so you can inhibit this, it can be really powerful, and it can be used to treat things like colorectal cancer, breast cancer, pancreatic cancer. So it just depends on what type of receptor it's targeted against, or what type of whatever the antigen the antibody is targeted against can be either very, very specific and affecting just one type of cancer, or it can be more broad, when especially with something like this vascular endothelial growth factor. What's interesting, though, is you can actually see a severe hypertension, which kind of makes sense, because if you're limiting generation of kind of new blood vessels, new blood flow, you can imagine how this may be able to cause hypertension just based on its effects on the vasculature, which is kind of interesting. Along with that, you can see things like proteinuria potentially worsen CHF in patients. Okay, so those are kind of the main biologic response modifier. Here's kind of a different one here. This is not going to be a monoclonal antibody. This is called Asparaginase, or Elspar is the brand name for this one. So this one's kind of interesting because asparagine, you know what asparagine is? Yes, it's a vegetable. It makes your pee smell a little weird. No, it's not asparagus. But asparagine is a necessary amino acid, right? So it's something that our cells generally can produce, right? So it's not one of those things that's I can't remember the term for it right now, but it's one of those things that our cells generally can produce on its own, usually from aspartate, right? And it's non-essential. Thank you. So it's a non-essential amino acid, right? So generally our cells can produce this on its own, no problem. We can use aspartate in order to do that. So we need that for protein synthesis. Without it, cells generally end up dying off. And so what you'll find is that what we can do is that normal cells, they can go ahead and take up aspartate from the blood supply. They can incorporate it in and use this asparagine synthetase in order to form asparagine. Can be very useful. What you're going to find is that with some of these cancerous cell lines, especially like lymphoid tumors, they have low levels of asparagine synthetase, so they have to take up asparagine, right? They don't have asparagine available. They basically just going to die off because they can't produce it on their own, right? Our cells can do that, though. Most normal healthy cells can do that. So what we can actually do is by using an asparaginase, right? This is just going to be an enzyme that's going to be able to break down asparagine into aspartate. Now our normal cells will take up that aspartate and generate it into asparagine, but those cancer cells cannot do that, right? They have low levels of this enzyme here, and so basically we're depleting their ability to get asparagine, and they are not going to be able to, or asparagine I should say, and they're not going to be able to produce new proteins. It kind of makes sense how that works. We're kind of starving out those cancer cells, while our other cells are able to can have the normal levels of enzymes to make that amino acid in the first place. I don't know if I used this joke already, but you know what you call a bad-tempered protein? Amino acid. So we use this occasionally in some lymphocytic leukemias. So again, we're using this in combination with other types of drugs, things like methotrexate, doxorubicin, vincristine. Again, by utilizing multiple mechanisms here, you can see how we can get some synergy happening. It's kind of interesting, though, with this one, you have to give methotrexate first, because you're going to find this asparaginase actually stops protein synthesis and will keep the actual methotrexate from working in the first place, right? So you need those proteins to be developed in order for methotrexate to really be functional, right? So again, it's working on that. You guys remember the mechanism for methotrexate? It's a dihydrofolate reductase inhibitor, right? So it's preventing utilization of folic acid. So we give that first, and you kind of end up with having asparaginase again towards the end there to help prevent that protein production. Yes, ma'am.
Is this related to like aspartame?
Well, aspartate, right? So we saw that was, but aspartame probably. Actually, I don't know the actual interconversion there. Someone else might know. Any of my dietitian-friendly friends here. We should look it up though. Why don't you look it up and then you can report back to the class? Yep, give yourself a little homework assignment. All right. Anyway, so it's kind of interesting some of the side effects that come about from this. Not really, you think, related to the mechanism itself, but certainly some allergic reactions, because again, this is a protein we're giving because it's an enzyme. But you can see things like intracranial hemorrhage, pancreatitis, which again, not something you think about related back to the mechanism. At least doesn't make a lot of easy sense there, but unique side effects you're going to see with that. You also end up seeing ammonia toxicity by affecting amino acid metabolism and whatnot. Again, ammonia toxicity is usually something you see with more like hepatic patients. Patients will have cirrhosis and things like that. Ammonia itself is pretty neurotoxic. It can cause a lot of ultramental status and encephalopathy and things like that. So it's certainly definitely not something you want to get rid of. We'll talk about a drug that can get rid of ammonia in the GI section later on. Okay, we also have some immunotherapy. So this is kind of interesting because these are going to be drugs that basically can help to stimulate the immune system to go ahead and try to fight off these cancer cells. We're kind of kicking our own immune system into overdrive here. And so we're going to have a few drugs that can do this. And basically what you're going to find is that our tumor cells are going to be less antigenic than foreign cells, but to some degree our body can still detect there's probably something off of these cells and try to stimulate them to get rid of it. So we're going to see there's lots of side effects associated with these, but they can be useful in some cases. So one of the ones we have is called interferon alpha. There's a couple of different varieties here. So we have like this alpha 2A and alpha 2B. Regardless, though, it's going to be able to increase the cytotoxicity of kind of our natural killer cells, right? So it's going to stimulate that cell line. It's going to help to make macrophages more phagocytic, and they're going to be able to kind of munch down on those cancerous cells. It will be able to make that macrophage kind of present those antigens more readily to those T helper cells. So again, we are helping to stimulate our own immune system to help get rid of these cancerous cells. There's one other indication you'll see interferon being used for more commonly. We'll talk about it when we talk about like things like HIV and hepatitis more specifically. So we used to use these drugs pretty commonly for things like hepatitis C. So that's one other indication we see it being used occasionally. So you can use it for things like hairy cell leukemias, Kaposi sarcoma. Do you remember who gets this type of cancer? Yeah, more AIDS patients, right? So this is kind of more progressive HIV to the point where they develop this. But lots of different types of cancer. Sometimes you can even see for things like multiple sclerosis we use occasionally. Nowadays, you have a little bit better drugs for things like that and Hep C, but so we don't use it quite as much. But it's a really kind of a nasty drug to give. We really don't like it very often, to use it very often because of the side effects we're going to see with it. But again, because it's a protein, we're going to give the sub-Q, and you get multiple times weekly. And they can get up to about 12 months or so. It's kind of the typical time frame they'll be on it. And again, you can see some allergic reactions associated with this because it is a protein, but it's actually the human form, the own interferon that we can make ourselves, but it's made actually in E. coli. We've kind of engineered the E. coli to produce this for us to get this drug. So the adverse effects, why we don't like to use it, certainly because we're kind of kicking up our own immune system. It's like we're giving ourselves kind of like a faux infection almost. We're trying to get, and so we see a lot of flu-like symptoms, a lot of myalgia, headaches, things like that. What's also really interesting is a lot of the CNS effects you see from this. So if you ever have a Hep C patient who's on interferon and another drug called ribavirin, they're usually like the worst people to be around because they get very, very aggressive. They get very cranky a lot of times. They also, they call it like their Hep C brain sometimes, or their interferon brain. But it causes aggressive behavior, depressed mental status, worsening depression, confusion. So it's a very, very nasty drug from the CNS standpoint. And also, this would be contraindicated. Most of these drugs are contraindicated in pregnancy, but this one is especially since it gets passed down to the fetus. It's kind of interesting because if you have a patient more familiar with interferon being used kind of more consistently for Hep C, but it's one of those things where like even a male patient who's on interferon does not want to get a female pregnant because of some transfer of that drug that can lead to some teratogenic effects. So again, it's one of those things where you got to make sure the patient's going to be on it for that year. They don't plan on getting pregnant that year. They need to make sure they're using protection for that time frame. Kind of similar to how like guys on Accutane did. You want to make sure they're not going to be getting anyone pregnant potentially. Another one we have here called aldesleukin. This is basically IL-2 or interleukin-2 we have engineered ourselves. Very similar to the interferon. We're kind of kicking up our own immune system, trying to get it into overdrive to try to get rid of some of these cells. Also, it can regulate proliferation, things like T cells, B cells, and other thymocytes. So again, we're going to be stimulating that proliferation of these kind of lymphocyte activated killer cells, and also these tumor infiltrating lymphocytes. So specific cell lines are going to be kind of stimulating in order to try to get rid of some of these cancerous cells. And again, you might use this as given as an IV agent, either as a single dose or as an infusion over like a 5-day cycle, essentially. So again, giving time between cycles to allow for the body to recover, because again, this can be somewhat toxic to us as well. So again, this is still risk for having allergic reactions because again, we're still having some E. coli, production being used here, which can have some cross-contamination of that. But sometimes you'll see it used for things like renal cell carcinoma, different things. Typically, these are kind of held off and used for more kind of metastatic, more kind of severe cancers. Again, don't memorize the indication specifically. Just kind of be familiar with the type of drug that it is, what's the mechanism, what type of side effects you can see with that. Again, lots of kicking your immune system up. So you're going to see lots of fever, chills, myalgia, all of that. And what's interesting here, you can actually end up seeing this capillary leak syndrome. This happens very, very commonly, and why we don't like to use this drug too often. But it can lead to things like hypotension, and 70% of people require pressor therapy. Anyone know what that means? Sorry, squeeze your patient really hard. No, it's not that. Basically, it requires you give a drug, a vasoactive drug, to try to squeeze down into the blood vessels. So this can include things like epinephrine, norepinephrine, dopamine, things like that, to try to get the blood pressure back up. So again, not a very good medication from a side effect standpoint. But if they have metastatic disease and this is the last drug they can use, then that's what you may have to decide to do. Associated with that, you can also see some arrhythmias, heart failure, all of that. So very, very nasty drug from that standpoint. You can see coma associated with the CNS edema. So again, lots of third spacing of fluids, lots of leaky capillaries where you can see a lot of fluid buildup, even in the CNS. Okay. Obviously, just use it in caution patients have any kind of pre-existing cardiac disease, renal disease, pulmonary disease. Just be careful if you use it on anyone, essentially. So, so kind of that's all the drugs we're going to cover for chemo. The last couple of things I kind of want to talk about are going to be kind of some maintenance things as far as how do you take care of these patients, essentially. So one of the things you always want to consider when dealing with chemotherapy is that a lot of these regimens are going to be count dependent. And I kind of mentioned that term before. What do you think that means? You have to give their immune system time to recover, right? So you can't just keep driving down their immune system at forever, because what's going to happen to your patient? They're going to get an infection. They're going to die, right? They need to have some sort of immune system in order to function. And so this is why some of these things will be count dependent. We want their neutrophil count, and we're going to look at absolute neutrophil count. You guys know how you get that? If you're looking at a CBC. Yeah, with a differential. So basically what you can do, a lot of things like neutrophil, basophil, those are expressed as percentages of the total white count. You can basically take that white count and then multiply it by the neutrophil percentage and get your absolute neutrophil count, right? It's kind of the simplistic way to do it. And so that'll tell you basically, and a lot of these regimens will have limits saying like, okay, you want to get up to 1,000 or you want to get up to 500 or whatever it happens to be, because we know that when we give these drugs again, it's going to knock down their immune system, right? So the heme system needs time to recover. You also want to look at things like monitor platelet activity, make sure that they have enough platelets, otherwise they can be at increased risk for bleeding and whatnot. And then just looking at organ function. So in some cases, you're monitoring for things like renal function, especially with drugs like cisplatin, right? Your platinum-based drugs, or if you're thinking about things like cytarabine, like these are drugs you want to make sure they have good renal function, not holding on to too much of it. Now, we can also look at things like urinalysis to make sure the specific gravity is such that they are getting well hydrated and they're able to flush those drugs through without too much issue there. And then also watch out for how these drugs are being dosed. So this is one of the most important things that we do. And the normal process, so just kind of give you an idea. So say you're in the hospital and you're writing an order for, say, morphine for a patient. So the typical process is you decide, I want to give morphine to my patient. You write an order. The order gets sent over to the pharmacy. We say, yes, that sounds good. And then the nurse can give it, right? Only like 3 people are actually kind of interacting with that med, essentially, at a minimum. When you're giving chemotherapy, the thing we do is that we'll have one hem-onc provider, could be like the nurse practitioner or the PA, whoever's working with the doc. They will write the orders. They will sign it. The hematologist oncologist will come in. He will sign it as well to make sure that it's correct. Then it comes to the pharmacist. We will sign it. We will verify, make sure everything looks good, and verify it. A second pharmacist will come in and verify it. Once it gets produced and it goes over to the nurse, then you need 2 nurses just to verify that as well in order to give it. So why do we do all these double checks? They're so toxic. We're giving people poison on purpose, right? So because of that, there's lots of checks that go into it. There's lots of safety features that go into it. I mentioned, vincristine. If you give it intrathecal, if you give it the wrong route, the patient's dead, right? So this is very high-risk medications, and so there's lots of things we put into place to make sure that we're giving it safely. So you want to look at things like how's it being dosed, right? So again, depending on the regimen you're looking at, the dosing may change from either weight-based dosing, meaning they're getting so many milligrams per kilogram, but oftentimes we're using things based on body surface area, right? So body surface area is nice because not only does it take into account the patient's weight, but what other things that factor in? Not age usually. Usually their height, right? So it's usually height and weight or what they're taking into there. Because again, this is nice because if you have a very large patient who happens to be very, very short, they have a different body disposition than someone who is still weighs the same amount but is very, very tall and skinny, right? So because of that, you're factoring in the height there, and you're going to find that weight is going to have less of a factor. Because again, I can have a patient who weighs 600 pounds, and if I'm dosing a drug based on milligrams per kilogram, there's a big chance that I can actually overdose that patient, because at that point, most of them are just going to be adipose tissue, right? And so you may think I'm exaggerating. I say like a 600-pound patient, but they show up in the ICU every once in a while, and so they exist, right? So you got to be careful with that. So by factoring in height, you help to eliminate that effect that height or that weight is going to have on the calculation, and so it can be much more accurate when you're doing that. So a lot of drugs in chemotherapy or in oncology are dosed based on body surface area. So that's one thing you want to focus on, and then some of it could be age dependent as well. So we see this more often with pediatric indications, but in some cases it'll switch. So if the patient's less than 2 years of age, we will do weight-based dosing, but then once it gets above 2 years of age, we'll go over in the new body surface area. super important that you don't screw that up, because you can end up goofing up the dose pretty significantly either way if you're not using the correct one, right? So again, this is why we're doing these double checks. This is why so many different eyes are going to be on these things. Has anyone ever heard of the Swiss cheese model for medication errors? I get to be the first person to tell you about the Swiss cheese. This is great. Basically, Swiss cheese, lots of holes in it, right? Usually when you're in a hospital setting or you're in the healthcare setting, typically if you goof up, if you make a mistake got through one hole, right? But usually there's another person there that can block it up, right? Or there could be a third person that could block that mistake from occurring. Every once in a while, you're going to have this magical thing occur where every hole matches up, right? So basically every single person in that line, you think someone's got to catch this error. No one catches the error, right? And then it makes it to the patient. That's when you can have something like a sentinel event, which means someone either has died or they have permanent harm or something like that. You want to avoid those whenever possible. So because we're putting more eyes on these things, we're doing these double checks, you kind of help to introduce more pieces of cheese in order to make sure that at least those errors, if they occur, get blocked up by one of those pieces, right? So you want to be the least holy piece of cheese you can, but everyone's got holes in them, unfortunately, and so everyone makes mistakes. And so this is why it's so important we have these double checks here, because you can kill somebody very easily with these drugs. Anyway, not to scare you or anything, but you'll hear about Swiss cheese models and the Joint Commission and all that at some point, so at least I get to be the first person to taint your mind with my goofy analogies. Anywho. So I mentioned that these drugs are not only dangerous for the patients who are receiving them, but also for the people who are handling them. So this is going to be more on the side of like the nurses who are managing these things, or like the pharmacy personnel who's making it. But appropriate PPE, which stands for personal protective equipment, has to be utilized. So you may be in a case where you're around these patients, or you're going to be helping to administer these medications. Like if you're, say, someone's giving intrathecal chemotherapy, you need to make sure that if the drug has a chance to aerosolize, that you are wearing respiratory protection, right? If you're around when these drugs are being administered through an IV, like those IVs can spill, right? We have special materials that we can use to try to prevent that from happening, but the mistakes happen, right? So things like shoe covers, gowns, gloves, super, super important. The other thing you want to think about is that, say, especially if you're dealing with like a pediatric patient, you give them chemotherapy and then they have a wet diaper. Well, that diaper is now contaminated with chemotherapy, right? So you have to consider even that can be potentially a hazardous thing and needs to be disposed of appropriately. So I'm not going to go over disposal medications here, but just be aware that even patient excreta, vomit, urine, any of that can be potentially contaminated for that short period of time afterwards. So usually, say 24, 48 hours after the end of chemotherapy, they're still considered to be contaminated from that standpoint, which is important for make sure you get rid of stuff appropriately, because you don't want you or someone else that you're working with to be potentially contaminated and see some toxicity from this. And then looking at supportive care, right? So we want to make sure we're not killing our patients, right? So we want to make sure that we can recover them after we give them these very toxic medications. And so from a hematologic standpoint, myelosuppression obviously is the most common dose-limiting side effect, as we've kind of alluded to with all these different medications. And so generally it takes time for the hematologic system to really kick back up into gear, right? So for instance, you can find that white blood cells, they typically will deplete, the actual depression can take time to develop. So for instance, white blood cells, they deplete faster than platelets, and that's due to their half-life, right? So they usually have a lifespan of about 6 to 12 hours versus 5 to 10 days or so. So you can see, and especially depending on the drug you're dealing with, some of them can be delayed even up to like 2 weeks in some cases, or several days before you really start to see that myelosuppression. And then anemia itself, because red blood cells stick around, you have about a 120-day lifespan. You may not see anemia for some time until after they've received the chemo, say several months. So all that takes time. And because of that, there are going to be increased risk for things like infection, anemia, and bleeding. And actually, one of the things it's really important to note is that certain routes of administration should not be used in patients who are neutropenic, right? So imagine if I have a patient who is not able to take anything orally because they receive chemo and they have mucositis, right? So they have all these sores all in their mouth, and they don't want to take any medications by mouth. And so I said, well, you have a fever. I'm going to go ahead and give you rectal Tylenol. That can be a problem, right? Because not only is chemotherapy causing mucosal damage, making that mucosal tissue at the rectum thinner, more friable. Anyone know what that term friable means? Yeah, more kind of brittle, weak, right? More likely to break, essentially. And then not only that, but now, what's kind of living around the rectal area. Yeah, lots of bacteria, right? So lots of bacteria, and now they don't have a very good immune system because they're neutropenic. You can actually introduce new bacteria just even by either doing a rectal temperature check, which we don't do too often for these patients, and then rectal administration of medications can lead to infection and potentially some pretty severe consequences of that. So, if you have a neutropenic patient, don't want to give them rectally administered medications. That's one route that's actually contraindicated for them. One reason why you might switch over to use IV instead in those cases. Also, think about things like if you're neutropenic, you don't have a very good immune system, how well can you generate a fever? Not super well. Sometimes you may not even see fever until much later on the disease process. Sometimes fever may be the only sign of infection that they may show. And so we have a lot of these patients who come into the ER. We call them febrile neutropenia, where essentially they come in with a fever. We know they're neutropenic based on their CBC with diff, and we have no active source for infection, right? So lungs sound fine, urine looks okay. We do blood cultures, but those take time to come back. And so it's one of those things where like, well, we don't know why you're sick, but we know you have a fever. So because you're at high risk for having these really nasty infections, we're going to go ahead and treat you anyway. So a lot of times we'll admit patients for that. We'll give them things like ceftriaxone, which is nice, kind of a broad third-generation cephalosporin, or in some cases we'll actually give them cefepime. Or cefepime as being a fourth-generation cephalosporin, even broader coverage, right? That actually gets Pseudomonas and things like that. And so again, we'd be very, very careful with these patients and usually err on the side of caution. So that's one thing to consider. But also, like, taking fresh flowers to your chemo patient who's in the hospital, right? That can be dangerous as well because what lives on flowers? Bacteria, right? So we don't want to do that. We don't want to give them extra pathogens. So if you ever go to like hem-onc unit, you may notice there's like fake flowers everywhere. That's probably why is because they don't want to deliver fresh flowers there. And then things like fruits that don't need to be peeled, right? So like something like an orange is probably okay because you're peeling that and it's relatively protected. But them biting into an apple could be lots of bacteria on there that again could be a source for infection. So little things you may not think about, but are a direct result of the chemotherapy that we have given them. These precautions you really need to take. So again, we can either correct this with time. So again, over time, the body will naturally kind of reestablish itself and will kind of perk back its own immune system. Some cases we can replace things, right? So we can give people platelets, we can give them red blood cells. We don't really give them white cells necessarily, but we can replace some of these things. Or what we can use is called a colony stimulating factor. And so looking at here, you can see the different kind of cell lines that will develop. And so obviously you have things like platelets developing here. You have like your lymphocytes, and then here we have things like red blood cells, and then we have our granulocytes and non-granulocytes being developed here. So looking at this, we can actually give synthetic versions of the hormones that the body would produce anyway in order to help stimulate their bone marrow to start producing these things. So we can give things like erythropoietin, right? So we have synthetic erythropoietin that normally is made in the kidneys. We can give it the IV and help to stimulate the red blood cell production. That's one thing we can do, right? We also have these granulocyte macrophage colony stimulating factors, or just granulocyte colony stimulating factors. I'm not going into specific products, but just know this is something we can give these patients, and this will help to stimulate replenishment of their white blood cells, right? So we have specific drugs that can do that. Obviously, who might that be a bad idea for? Yeah, they have leukemia, right? So you have to be careful with this. If it's something like they have brain cancer and we depleted their immune system, we could potentially give this to help recover them, and that helps you to hit those counts faster, those count-dependent sections where you can't give chemo again until they've recovered their neutrophils to a certain point. Okay, so just things to think about. And as far as GI effects go, again, nausea, vomiting is the most common side effect you're going to run into with all these chemo agents. And again, we'll discuss antiemetics later in the GI section next semester. But just be aware of things like the mucositis can be very, very painful for them. It can be, again, another source for infection potentially. So this is why oral hygiene is so important for these patients. So you need things like salt rinses can be useful here. So just kind of warm saline rinses can be nice in order to help get rid of some of that bacteria. And then also we have a drug called chlorhexidine or Peridex. You've probably seen this if you've ever been involved in the surgery world. But this is another thing we can give. Basically, it's a swab that the patient will have, and it is anti-infective. They can basically just wipe out all that stuff and they can spit it out essentially. So that's another common thing we use for a lot of our hem-onc patients. They'll just kind of swish and spit and hopefully keep their mouth pretty clean. But just be aware you may need to use things like IV hydration because they can't drink very well. You may need to give them total parenteral nutrition through the veins, so that way they actually get some nutrition as well. So it can be very, very significant with that. Okay, so this is an example of an antiemetic potential or emetogenicity chart, right? So this is not the entire chart, but just to give you an idea, and I don't want you to memorize anything from this chart necessarily, but looking at the risk for emesis associated with giving these chemotherapy agents, right? So looking at things like, where's a good one? It's like carmazine, BCNU. This is a high risk. Greater than 90% of your patients you're going to give this drug to are going to throw up. We don't want patients to throw up. Who likes to throw up? Nobody does, right? It's awful. So we give lots of drugs to prevent that. So we'll use things like, anyone heard of Zofran before? So, for instance, we go through Zofran like water in the hemonc units, right? We'll look at a lot of other drugs that are going to use in conjunction with that, but it's important to know that what type of regimen they're getting. If they're getting things like doxorubicin, especially some of these are dose related. So, for instance, doxorubicin greater than 60 milligrams per meter squared is a very high risk versus if they use a lower dose, it would be more of a kind of a moderate risk, right? So we're making sure that we're giving antiemetic regimens that match up with how emetogenic the drugs we're going to give are. Okay, so that's important to consider because again, if they're throwing up, some nutrition issues, a dehydration issue, it's just no fun for the patient. As far as skin goes, unfortunately, as far as the alopecia goes, there's not a whole lot we can do for that. Maybe you can rub some Rogaine on the head, but it's not really going to be all that effective because you're killing off those rapidly dividing hair cells. But typically, there's no good pharmacotherapy for this. It will come back with time. Sometimes it'll actually come back with a different kind of character to it than it did before. So you may find patients say had straight hair before, and now it comes back kind of wavy, things like that. So unfortunately, nothing we can do for that. But the other thing to worry about is extravasation. You guys remember what that was? Yeah, so basically we have the drug is exiting the vein in the subcutaneous tissue, causing pretty significant damage. We talked about the vinca alkaloids being bad for that, the taxanes, the anthracyclines like doxorubicin. Keep those in mind and just know that they can cause very severe damage. This is something you need to treat as an emergency when it occurs. So if the nurse calls you up and says, hey, I think I blew this vein, I think I'm extravasating doxorubicin, like, it needs to be handled immediately because time is tissue, and so you want to handle that quickly. Every hospital generally will have a protocol for how to deal with these. Some of them the goal is to try to absorb that drug into the systemic circulation as best you can. So some of them require hot compresses, some of them require cold compresses, and in some cases we will give additional drugs in order to help dissolve and make them absorb a little bit better. So we can have things like hyaluronidase or Hylenex. This actually breaks down subcutaneous tissue. The connective tissue there will help to dissolve some of that so that it can be absorbed better. That's one thing we can do. And then there'll be some other ones we'll use. There's a solvent we can use called DMSO, and you'll see that if you're working in this kind of field. But just be aware that it's something that needs to be treated, needs to be taken care of immediately. There's lots of ways we can do that. Okay, so that's it for chemotherapy, oncology. Any questions? You guys are all super jazzed on hemonc. You're like, I'm gonna go work in that field forever now. I don't like it either, but it's okay. So you got to know about it. Questions all. So this is the end of the exam material for Farm 1. I got a review session left, and you guys are done with Farm 1. Congratulations. You guys will feel better after the test, after next Friday. And you guys can go out and partay or whatever you guys like to do. So we'll do the review. I think it's next Wednesday's review. Does that sound right? We'll do another Kahoot. If you have any questions in the meantime, then let me know. Otherwise, and don't forget your assignment, right? The prescriptions you guys are all writing diligently and very legibly, I hope. You'll be able to turn in on time. Okay. If you have any questions, then let me know. Otherwise, I'll see you guys later. Yes. What your question?
Is that just for participation? Because there was like a point system.
Yeah. So that's going to be I'm workshopping this. I'm going to utilize that for next time when we do this in Farm 2. This is just I want you guys to get practice with it. I want to see how it works, and it's really just participation at this point. Okay. But everyone still has to do it. Otherwise, there will be severe repercussions, of which I will determine if that happens. But I believe in you guys. So. I'm sorry? Yes. It doesn't matter. I just want you guys to get into practice, because some people are like copying and pasting it from the example, and I didn't want that to use the same license number. The content of the script is what I'm more concerned about. Okay.